there kind of non-specific signs that you're seeing on the little image here? Yeah, for sure. Like paleness, coldness, yellowing, or shortness of breath, weakness, fatigue, dizziness, low blood pressure, palpitations. Are all those kind of what we call non-specific symptoms? Yes. I don't know what they are. They could be many things. They could be nothing. So just be aware of that. Okay, let's take a look at blood loss. So we're going to look at each one of the types of anemia, starting with blood loss first. Okay. So blood loss, we have what's called hemorrhagic anemias. Okay. So what does hemorrhagic anemia mean? Hemorrhage means to bleed, right? You're basically bleeding out. And we can classify hemorrhagic anemia into two, acute and chronic. So what does acute hemorrhagic anemia mean?
Sudden
Trauma.
Sudden, now, trauma, stabbing, GSW, right? Like you see here, gunshot wound, right? What artery could be hit there? We have the subclavian artery. What if that's hit, right? So blood pressure, he came in at 120/80, and then in a matter of like 2 minutes, 3 minutes, he's 80/60. What's that telling you? He's crashing, yes or no?
Yes.
For sure, right? So we gotta be aware of that. Is that acute or chronic? Acute. Make sense? Treatment. Underlying cause, of course. If he's bleeding out of a gunshot wound, you gotta treat the gunshot wound. And then what do you have to do? If we're 6 liters and he lost a liter, what do you need to do? Give him blood. So usually blood transfusion, correct? Make sense for acute? We go with that? By the way, for the quiz, you gotta know all the pathologies, all of them. I'm gonna ask you all pathos for the next couple quizzes, next couple slides. We also have chronic hemorrhagic anemia. What does that mean? Ongoing, persistent, long-standing. It's happening for a long period of time. So we talked about hemorrhoids early, correct? If someone has a significant amount of hemorrhoids and it's not treated and they keep bleeding out over time, can they have blood loss from that? Can they have hypoxia from that? Yeah, for sure. What about an ulcer, like a peptic ulcer disease, right? If it's eaten away, like you see here in the images, this is an upper end endoscopy, and you can actually see in picture A and I think it's A, I think, shows you pretty good. These ulcer points right there. The mucosa has been eaten away, the person's basically slowly bleeding, right? So what happens to their blood levels? Drops, correct? So what type of anemia is this? Chronic hemorrhagic. So how do we treat this if it's an ulcer? Treat the ulcer. If it's hemorrhoids, we call that treating the underlying cause, right? Treat the underlying cause. Does that make sense for these two anemias, the cause? Okay? Okay. So let's take a look at the next one, which is low RBC production, okay? So low red blood cell production. Remember, we need what? Iron. Is iron important to make hemoglobin? Yes, it's essential. Basically, when we take a look at iron deficiency anemia, basically it can be caused by a wide range of things. We can see it with, like we saw before, hemorrhagic anemia, but the most common cause is this right here, okay? It's low iron intake, yeah? But again, can you see with hemorrhagic anemia, like we talked about before, who's at risk here? Females, right? Why are females at risk? Of reproductive age. Menses, menstrual cycle, they're bleeding out. Is it hemorrhagic? Yes, it's hemorrhagic anemia, okay? I don't know if it's acute or chronic, really, it's kind of like physiological, right, anemia kind of thing, right? But it is hemorrhagic. They are losing blood, so they are going to be anemic. But the cause there is a little different. What's the cause there? I mean, you can't stop menses. I know I joked about that earlier. I said bleed less, but that's just a joke. You can't bleed less. What's going to happen? You got to treat. You can't treat the underlying cause because it's a normal physiological phenomenon. What do you have to do? Increase your stores of what? Iron. How? Before the supplements. Diet. Right? We're always going to go with dietary modifications first. For you guys too, it's very important that when you guys tell your patients and advise your patients, we never say, take this pill or take this medication first, because what do they hear? And you start talking about other things. The only thing they're going to hear is the pill. You said pill. You didn't say, they didn't try to listen about exercise and weight loss and diet and anything. You said pill.
An easy fix.
Easy fix. So that's always the last thing that we mention, right? It's always, behavioral, it's dietary, and then it's going to be pharmacological, okay? So again, I won't ask you this on the quiz, like I'm not going to show you this on the quiz, but just so you guys can compare the difference between normal and then anemia. Do you guys see the difference just generally, right? Essentially. And what's the treatment here? like we said before, increased dietary intake of iron, like we said, leafy greens, or iron supplements. Does that make sense to you guys? You guys go with that one? Okay. So again, what's the most common type of anemia? Iron deficiency. Who's most at risk? Reproductive females, right? Okay. This one's a little different. This is called pernicious anemia, okay? Pernicious anemia is an autoimmune disease, okay? So what does autoimmune mean again?
Cells are attacking.
The cells are attacking itself. My body's own cells are attacking my own cells in different parts of the body. This is a disease of vitamin B12, okay? This is a disease of B12 deficiency, okay? Because what happens? In my stomach lining, in the mucosa of my stomach, I secrete many, many things. There's a lot of enzymes, a lot of hormones, a lot of factors that are produced. A very important factor here is called intrinsic factor, okay? Intrinsic factor is produced by the lining of the stomach, the mucosa, and it's needed in order for me to absorb B12. If I don't produce intrinsic factor, no matter how much oral B12 I take, it's not gonna couple, I can't absorb it. Okay, if I cannot do this process, an anemia manifests, right? What is the name of the anemia that manifests? It's called pernicious anemia. What's the root cause of it? It's B12 deficiency. Why is the person B12 deficient? If they're eating, right? Because everything has B12 in it, by the way, guys. You know that, right? Almost all foods are fortified by B12 and folic acid. Even like Flamin' Hot Cheetos and Doritos and all that kind of stuff. Look at the ingredients. You're gonna see folic acid. I'm not saying they're nutritious. I'm saying they have it in there.
But they are delicious.
They are, but I'm saying, I didn't say they're not delicious. They are delicious. They're very delicious. But not nutritious. Did I say that? I said nutritious. I didn't say delicious, correct?
Yeah.
Yeah. Okay. They're delicious but not nutritious. Delicious but not nutritious. Not the other way around. Okay. But they have folic acid. They got iron. They got all those things in them. All your foods, even white bread's kind of fortified with folic acid, B12, all that kind of stuff. So people here in the States don't present with anemias, essentially. But if there is an autoimmune disease, like we said, if the stomach lining is being eaten away, and within my stomach lining, I'm making intrinsic factor to couple with B12 to be absorbed later in the gut. If I don't have that, what manifests? A special type of anemia. What type of anemia? Pernicious anemia. Does that make sense? So what's the treatment for this? Oral? You have to inject it, right? Intramuscular, right? Injection. Yeah? You guys see the nurses at the pharmacy, at the grocery stores? Set up shop, you guys ever see those? B12 injections, like $22 or whatever it is, right?
I do it. It looks like Kool-Aid.
Yeah,
It's red. It's weird.
yeah. Yeah, it's got this kind of like, it's the cobalamin in it. It's the cobalamin is the redness of B12. So it gives it like a reddish orange tinge to it, a red or reddish tinge. You're right. B12 injections, you gotta give it parenterally, we call it. So we gotta give it another route. So if the person, no matter, like I said before, if it's autoimmune and the stomach lining is messed up, no matter how much I give orally, is it gonna work? No. Parenteral, it's gotta be injectable. Usually intramuscular, IM. Does that make sense? Good? Okay. Here's another one. Low RBC production, okay? So here we have an issue with what hormone? EPO. Where's EPO made? So what would impede the kidneys from producing EPO? If my kidneys are healthy, I don't gotta worry about it, yeah? But let's say I have kidneys like this, right? This is called polycystic kidney disease. Do you guys see the cysts? You guys see the CT scan? These are the kidneys. They're like triple the size. Look at that. That right there, this is another view right here. All this is kidney. That looks almost like the liver, right? Those are grossly misshapen. Look at that. Huge. Are they functional, do you think? No, they're non-functional. So if my organ, again, let's look at the hierarchy of things. If my organ on a gross level, macroscopic level is not working, do you think if I go in on a microscope, do you think those cells are gonna be functional? No. So what is this cell not producing? EPO. So how's the patient gonna present? With what?
Lethargy.
Yeah, all the symptoms there, they're gonna present with low red blood cell, which manifests as what? What are we calling this? Anemia, right? They're gonna present with anemia, right? But we understand what the cause is. You understand how there's so many different types of anemias, but we're understanding the root causes of the different types of anemia. I wouldn't treat this with iron, would I? Would iron work for this? Oh, let me give him B12. Yeah? No, because what's the underlying issue? The kidneys. So what are the kidneys making? EPO. What do I give? EPO. Well, dialysis for the other whole other thing that's going on with the patient. Yes, dialysis they have to. Otherwise, they're going to die for sure. But I'm saying specifically for the anemic aspect of it, it's going to be EPO. You guys good with that? Okay. There's also something called aplastic anemia. Aplastic anemia basically is a disease in your bone marrow and your blood stem cells. And basically those cells are damaged, okay? So I'm producing EPO, maybe my kidneys are functional, right? But what's damaged now? My bone marrow. Where are my red blood cells made? In bone marrow. So now if you look here, this is a patient that underwent chemotherapy and radiotherapy, and it kind of destroyed their bone marrow. Certain viruses can do it too, but a lot of times it's by drugs or chemicals. Radiation can do it too. And if the red bone marrow is done, this is a type of what we call aplastic anemia. How would we treat this? I mean, short term, you can treat with transfusions, of course, because if they're not producing red blood cells internally, where can they get the blood from? It has to be external, right? Transfusions. You'd have to give them like all these different types of cells. But long term would be what? A bone marrow transplant, right? It's one of the indications to go through a bone marrow transplant. Is like your cells are not working right, and basically your whole genetic code is messed up, right? So the only way to fix it is to do what? To reset. How do you reset? You have to transplant new marrow there. Otherwise, the problem will never get fixed. Does that one make sense? It's called aplastic anemia. Okay, let's take a look at high red blood cell destruction. Okay, so now we're looking at anemia caused by the destruction of red blood cells. These are called hemolytic anemias, because hemo means what? The red blood cell, right? Lytic or lysis means to destroy, to lyse, to break down. So hemolytic anemia is when the red blood cell is destroyed. These are usually going to be genetic, right, in their definition. And you're going to have abnormal hemoglobin levels. And the globins on those red blood cells, like we talked about before, are going to be very fragile. You guys see these little misshapen red blood cells that I'm circling right here? Those are called schistocytes, okay? Schistocytes are abnormally shaped red blood cells. And they don't have the same resiliency as normal, healthy red blood cells do. They lack what protein that makes them pliable or flexible? Do you guys remember that one?
Yeah, wrote it down.
Spectrin.
Yeah.
Spectrin. So they lack spectrin. So because of that, their cell membranes are very fragile. When they get to end capillaries, what happens? They try to do it, they try to bend, and they what? They lyse, they break, exactly, okay? They lyse. So again, they're classified as hemolytic anemias, okay? So what are some important hemolytic anemias that we have to know? One very important one is called thalassemia, okay? Thalassemia. This is again genetic, okay? Don't forget that. And typically, certain diseases affect certain populations in the world, right? Certain individuals of certain ancestries are affected by certain diseases, yes? So sometimes your questions might tell you, you have a male, 20, of Mediterranean descent, right? What anemia do you think is most prevalent in this individual? And they'll give you the choice of thalassemia, or they'll give you the choice of sickle cell, or some other anemias that we just talked about. It would be thalassemia, correct? Based on the question you present. If they say patient of African or African American descent, right, presents with X, Y, and Z symptoms, what anemia do you think is most common in this individual? What would it be? Sickle cell. Okay, we'll look at sickle cell in a bit, but we're looking at thalassemia right now. Okay? Do we understand our population here? Okay? Okay. So again, it's caused by missing genes. It's going to affect how the body makes hemoglobin. You guys remember we talked about the globin chains? We had 2 alphas here and 2 betas down below, correct? So if those chains are misshapen, if they're not shaped correctly, is it going to affect the way I carry iron?
Yes.
Is it going to affect the way I carry oxygen? Yes. If the problem is with my alpha chains, could I call it alpha thalassemia? Yeah. If the problem lies with my beta chains, do I call it beta thalassemia? Yeah. So this is where the thalassemia arises from. We know exactly where it is, right? Can we treat this?
Yes.
it's genetic, right? I wouldn't know how to treat, it's not easy to treat genetic disorders, okay? Are you guys good with this one? Makes sense? Okay. Let's take a look at this one here. So this is a typical or classic, this is a smear. That's a sickle cell right there. I'll circle that one there as well. You can see that one there. And these are scanning electron micrographs. A sickle or C-shaped type of red blood cell. Sometimes they call it HBS. HBS, hemoglobin S for hemoglobin sickle. Basically, again, it's a hereditary disorder. It's genetic. This one's kind of interesting. It's a frame shift mutation where, you don't have to know this for the quiz, but just for fun. You have what's called glutamic acid, which is a type of amino acid, gets switched out for valine. And that changes or frame shifts everything that comes after the genetic code. And basically it creates this incomplete red blood cell, right? It's incomplete. It cannot carry as much oxygen. It's very, very fragile. Again, it lacks spectrin. Again, it occurs in individuals whose ancestry or who live in tropical or subtropical areas. That's sub-Saharan areas. That's the places where this type of anemia is most prevalent, or the genes or genetics of those individuals. You can say, well, my grandparents were born in this country, but I was born here. Why do I present with this disease? It's genetic. You know what I'm saying? So even if you're born here, the genes still follow you. Your gene pool still follows you. Okay? You'd have to dilute the genes to make it less prevalent, because we've got things that are called autosomal dominant, autosomal recessive, right? And it's part of the gene pool essentially. Does this one make sense to you guys? With this one? Okay. Last disorder to look at here is something called polycythemia vera. This one's interesting too, because polycythemia vera is what we call a myeloproliferative disorder. A myeloproliferative cancer. You guys know what that means? Myeloproliferative. What does myelo mean? What lineage? Myeloid stem cells. What's in the myeloid stem cells that we're looking at? Red blood cells. Yes or no?
Yes.
Yes. So what happens here with this particular cancer? This is normal, and this is abnormal. What do you see? Over, a lot, too many, too much, an overproduction of what cell? The red blood cell. Is that good? Hey, it's good. More red blood cells forming. That's awesome. No, because what can happen? What you're seeing with the patient, correct? This is pretty severe polycythemia vera. Look at that, essentially. You're totally messing with the normal physiology of the body. A lot of blood in the underlying tissue causes pruritus or itchiness, right? Iron is very irritated, it's itchy. Severe burning of the hands and the feet is very common to see. Gouty arthritis is also common to see in patients with this as well. And then of course, the big scary thing for us is what? If all this is kind of like moving slower than usual, what can happen? Clotting. So they're at increased risk for heart attacks and strokes, right? So very dangerous. So essentially, what is the treatment for primary polycythemia vera, or just polycythemia vera? It's phlebotomy. What's phlebotomy? Bloodletting, basically. You basically draw blood out, essentially, and get rid of it. Does that one make sense to you guys? Polycythemia. Secondary polycythemia, don't worry about that one. Just worry about the primary one.
Did you do like blood thinners too?
Yeah, you could. Yes, definitely. Yes, you want to give an anticoagulant. Yeah. So anticoagulants are going to be good because like aspirin, for example. Baby aspirin. Yeah, you can give clopidogrel. You can give warfarin. Those kind of things to basically ensure that they don't clot while you treat. Yes. Little cheat sheet. I would review this. Basically gives you all like the ins and outs of all the anemias that we reviewed. Make sense? Good? Okay. We're almost done. Okay? So hang in there. It's not even 8 o'clock yet, so be quiet. Okay? Don't yawn. I'm just kidding. You can yawn. 1 yawn each, okay?
Wow.
Good. Okay. Next up, we're done with the red blood cells. That's a good thing. We're done with red blood cells. Now we're going to move on to the next cell, which is the white blood cell, the leukocyte, the platelet. What percentage of whole blood does the white blood cell make up?
Less than 1%.
Less than 1%. Just food for thought, just so you guys understand. Anything over 10,000 usually have an infection. Yeah, it means you've got an infection. You don't have to know the numbers, but just be aware of that. What's the purpose of white blood cells? Basically protection, defense, right? Like we just talked about before, if we have something over 10, again, depending on the lab, 10, 11,000, numbers don't really matter. But anything over the normal baseline, we call that leukocytosis, right? So when a patient comes with an infection and you're writing your SOAP notes and you do your lab studies and all that kind of stuff, you're gonna say patient presents with leukocytosis, elevated white blood cell count, which means what? Infection. Okay, so let's understand leukopoiesis. Okay, so what's leukopoiesis? Leukocyte formation of white blood cells, okay? So do you guys remember what growth factor or hormone stimulates the progression of these white blood cells? What is it? Well, those are the stem cells, but what's the hormone or growth factor? For white blood cells. You guys remember? CSF, colony stimulating factor. Remember that one? So colony stimulating factor is the enzyme that's going to promote or stimulate white blood cell production, okay? Now there are different types, like I mentioned before, of colony stimulating factors for a specific type of white blood cell, but we're gonna keep it pretty generic and just know CSF equals white blood cell production. Make sense? Good? Okay. If we talk about lineage, Kathy, you're right. What lineages do I have when it comes to white blood cells? Lymphoid and myeloid. So what cells ultimately are going to arise from the lymphoid lineage? Lymphocytes. What about the myeloid?
Everything else.
Everything else. Just simplify. Everything else. Whatever. Everything else. Okay? Good?
Yes.
Okay. So if we look at the dynamics here of whole blood, right? We talked about this before. We got the buffy coat right here, the leukocytes. We have how many different types of leukocytes? 5, correct? And we have to know their order. This is important that you know what's most common, what's least common. We've got granular and agranular. We're gonna look at all that stuff. Okay, so decreasing in abundance, we're gonna go in that order. Okay? What's the most abundant cell that we have, the most abundant white blood cell? It's called the neutrophil. Okay? Makes up about 70% of my total white blood cell count. What's next? Lymphocyte. So if I were to ask you, where does the neutrophil arise from in terms of the stem cell lineage? Where does it arise from? The neutrophil. The neutrophil, where does it arise from?
Granulocytes?
No, remember, is it lymphoid or myeloid?
Oh,
Myeloid, right? Okay, the lymphocytes, about 45%. Where do they arise from? Where do they arise from? Don't fall asleep, come on, hurry, let's go.
Lymphoid.
Stay with me. Stay with me. You're failing, stay with me.
I'm so sorry.
It's okay if you say the wrong answer, it's all right. If you say the wrong answer, you're good. The lymphoid, yes, well, let's speak up.
I said 3 times.
I didn't hear
She
you.
did.
Did she?
Yeah.
Yeah, okay. I
What
need
was
it.
that?
What'd you say?
Lymphoid.
The lymphoid.
I said that.
Did you? I mean,
She doesn't listen.
I'm falling asleep. Give me a second, let me drink some coffee, hold on. Okay, next up, monocytes, eosinophils, and basophils. No, that's in order numerically. Numerical order, guys, numerical order. What's the most numerically elevated number here? Number 1, neutrophil. Number 2, lymphocytes. Number 3, monocytes. Number 4, eosinophils. Number 5, basophils. The order that you see here is ordering it between granulocytes and agranulocytes, right? I'm not talking about that here. I'm talking numerical value, highest to lowest. How do you remember that? Oh, we'll do it again. How do you do that? Never let monkeys eat bananas, okay? Because they go crazy. Yeah, check it out. Look, never let monkeys eat bananas. N. Say it. Neutrophils. Let lymphocytes, monkeys
Monocytes.
eat eosinophils. B. Basophils. In descending order. Yeah. Why not? Because they go crazy. Okay. If you're asking the why. Don't change. No. Never let monkeys eat bananas. Easy way to remember for now. Right?
Where
Later
do
on,
you get this
yeah. Good? Yes? Okay. So, what's a differential? A diff or a differential basically kind of looks like this, where it kind of graphs or tells me of the 5 different types of white blood cells that I have, which one is elevated. It's going to differentiate between one from the other and tell me, is this an acute infection? Is it a chronic infection? Is it an allergic reaction? Is it a parasitic infection? Is it a viral infection? It tells me all that. That's called a diff or differential. Does that make sense? That's what I want you guys to understand about this. Okay? So let's look at the classification now based on whether or not they are granular or agranular. So what does it mean when we classify these as granular or agranular? So granulocytes mean what? They're little what? Granules, right? Little granules on the surface of the cytoplasm, right? They're bumpy, basically. Agranulocytes mean what? No granules, not bumpy, smooth. Make sense? So granulocytes, which ones do I have in the granulocytes? Basophils, eosinophils, and neutrophils. And agranulocytes? Lymphocytes and monocytes, right? So this is the mnemonic for granular versus agranular. It's called Ben-Lem. Okay, Ben, B-E-N, Lem, L-M. Ben-Lem. So what are granular? Ben. What's agranular? Lem, L-M. Okay? So far so good?
Hold on.
Please don't change it.
Okay.
Yet.
Yet. So which ones are visible? Under light microscopy, which cells have visible granules? Granulocytes. Can you give me 3 granulocytes? Basophils, eosinophils, neutrophils. Okay. What are agranulocytes? What do they have or don't have? No granular. They're smooth. No granulocyte. No granular elements to them. Okay. We good, or still waiting? 2 seconds. 1, 2, done. Okay, so let's take a look at each one individually, because on the quiz you will have to know the differences between them. Okay, so let's take a look at them. Okay, so let's understand why they have these names, because it's going to help us. Okay, so it all starts with understanding right stain. Okay, what's right stain? Basically, the dyes that we use to give the cells their colors of red, blue, and purple, yeah? That's called right stain with a W, okay? So based on that staining, the cells get colored a certain way. So neutrophils, why are they called neutrophils? Because the granules, they don't attract the acid, which is the red dye, or the basic, which is the blue dye. So if they're not attracting red or blue, what are they? Neutral. That's why they're called neutrophils. Okay? Are they granular or agranular? Granular. Do you see on the surface of the membrane all those little dots there? Right? That's granular. Okay? What about eosinophils? Eosin means loving. So what do they love? What color do they love? Red or orange. So eosinophils are red loving. So what are they stain? Red. So what are you looking at here? B, eosinophil. Okay? Basophil. Oh, are they granular or agranular? Granular. You can see all the granules, correct? What's next? Basophil. Baso means basic loving. So what color is a base? Blue or purple? What color is this? Blue or purple. So that's why it stains blue and purple. And it's a basophil. Is it granular or agranular? Granular. Then you have 2 more. You've got the agranular. The lymphocytes, they basically take up the majority of the nucleus, if you guys notice, this giant thing here. And they stain dark, okay? And are they granular or agranular? Agranular. And the monocytes, they have a U-shape or horseshoe shape, like you see here. And they're granular or agranular? Agranular. Now the biggest point of confusion, I think, between students is understanding the difference between a lymphocyte and a basophil, okay? So the first thing to understand here is how these things stain and whether or not they're granular or agranular. So if you look at the surface of this cell, right, can you notice all the little granules, all the little bumps, all over, okay? Look at the lymphocyte. There are no granules on the cytoplasm. You guys see the white? The clear part of it? That's the cytoplasm. Look at the white here. There's no granules here, okay? There's no granules. Granules are little bumps. All these guys that you see here on A, B, and C are bumps, okay? That's the way you can tell the difference between a lymphocyte and a basophil, okay? Principle. Okay.
No bumps, no bumps.
Bumps, no bumps, basically. Yeah, granular.